Welcome to the symposium on the cysts of the jaws. In this, we're going to cover a lot of the pathological aspects of it. The management is going to be covered by Mr. Bolt. But we'll have a look at some of the features of the clinical, radiological, pathological parts of it. And we're going to split it into a number of different shorter videos so that hopefully you can get into the bits that you find interesting and make it a little easier for you to digest. The aims of that, as you can see here, we're going to cover various component parts in terms of pathology and cyst formation. And as far as the detail of some of these cysts are concerned, and there are a lot of them. There is a fairly big list. These are the main ones that we really want you to know in detail. And you can see here in terms of, it's a fairly short list, but the list of overall cysts will be much larger. So here's the outline of the sessions. And in this video, we're really going to cover pathogenesis and epidemiology, and then we'll cover the various other parts in later videos, so that, as I say, it's in digestible pieces for you to be able to dip into. So the first part of this is the epidemiology and pathogenesis of cysts of the jaws. Now we've really got to start with a definition. So a cyst is a pathological cavity, and it may have fluid, semi-fluid, or gaseous contents, and it's not created by the accumulation of pus, which I'm sure you'll remember that if a lesion is created by the accumulation of pus, it's not a cyst, it is an abscess. It is usually, but not always, lined by epithelium. And the cysts that we are going to have a look at in this presentation are lined by epithelium, but there are one or two others that you'll come across in other parts of the course where the lining is not epithelium. From a pathological point of view, a cyst has three components. It has a lumen, so that's going to be the solid, semi-solid, fluid or gaseous component of it. And then round that, enclosing it, is the lining, which may or may not be epithelium. And then supporting that will be a wall, which will largely be connective tissue. And that connective tissue will contain variable amount of inflammatory cells depending on the etiology. And when we're dealing with cysts of the jaws, we have to remember that this is a group of lesions which occurs in a larger context. They are lesions which are largely arising from the remains of the tooth-forming tissues, as do odontogenic tumours. And I'm not going to spend any more time on odontogenic tumours today. They are a subject of a later presentation. But it's difficult to completely separate them because they're arising from the same tissues. And you can see here that we tend to split the odontogenic cysts into those of inflammatory origin and those of developmental origin. But on the left-hand side, the odontogenic tumours are there. So how common are they? Well, we had a review of all of our pathology over a number of years in Sheffield, and you can see here that cysts come in adults and children, about 12–13% of all the lesions. It's dominated by oral mucosa, as you would expect. So they're relatively common. And when you think about them in terms of the lesions of the jaws, in fact, they dominate things. So odontogenic cysts, overall 70%, much bit more common than that in the adult population. And the other lesions of the jaws, like odontogenic tumours, fibroosseous lesions, and other bone tumours, are relatively rare by comparison. So it's a pretty large part of our diagnostic practice. So how do we classify them? Well, there are a number of ways in which you can do that. So at the basic level, you can split them into epithelial cysts or cyst-like lesions. The epithelial cysts themselves can be then separated into those which are of odontogenic or non-odontogenic origin. And the odontogenic ones can be further subdivided, as I earlier indicated, into those which have arisen from an inflammatory etiology and those which is a developmental etiology. And when you put that classification really into the list of cysts, this is it. Odontogenic cysts are outlined by epithelium. The inflammatory ones are the radicular cyst and residual cyst. Now, you'll have heard of these before because we've talked about them in the context of periapical pathology earlier in the courses. And then there's the collateral and paradental cysts. They are inflammatory because they are largely associated with partially erupted teeth. And when they're partially erupted, they tend to get inflamed. And so a cyst can form around them as well. We'll talk a bit more detail in a minute. Then there are the developmental cysts, and there are a large number of them. The follicular cysts are by far the most common, but there are others. and some of which, the nature of which is not entirely clear. For example, the odontogenic keratocyst and the calcifying odontogenic cysts, as you will see, have asterisks beside them, and they're ones of which there is some controversy about whether they might actually be odontogenic tumours. So here in diagrammatic form are most of our cysts. The radicular cyst, the apical one, is at the apex because that's where the apical opening of the pulp canal is, and lateral radicular similarly because there's a lateral opening. If you take the tooth out but leave the cyst behind, you can get a residual cyst. And then the rest of them are developmental cysts. The follicular ones, dentigerous cysts, which are largely within bone, associated with unerupted teeth. If it's outside of bone and into the soft tissues here, it's an eruption cyst. Lateral periodontal cyst, there are inflammatory variants of lateral periodontal cyst and also developmental variants, so it's depending upon the etiology of them. Odontogenic keratocyst tends to occur as a multilocular lesion in the posterior part of the mandible. And then these here are the non-odontogenic cysts, nasopalatine, nasolabial cysts, which have an embryological developmental origin, again, which we'll cover in a little detail later. So when we think of how common they are, the radicular cyst dominates things. It's by far the most common of the cysts in its various forms, and the follicular cyst a good bit behind. But between them, essentially the radicular cyst and the dentigerous cyst comprise the vast majority of cysts of the jaws, and the others are relatively rare. So what about how they develop? Well, you need three things in order to get a cyst. The first of these, you need a source of epithelium. You need something to give you a lining. Then, given the fact you've got some epithelium, it needs to be provoked to proliferate. So that stimulus needs, we need to find that. And then once the cyst is established, there needs to be ongoing mechanisms to allow it to grow and to resorb the bone round about them so that it can continue to expand. So we'll deal with each of these in turn. So about a source of epithelium? Well, the odontogenic apparatus leaves little bits behind when it is complete. And there are three main sources of epithelium in this context. The first of these are the remnants of the root sheath of Hartwig. Now that structure outlines the root's shape and size and so on, and once it is finished and the root development is complete, it will fragment and mostly disappear, but some small remnants can be found within the periodontal ligament, and these give rise to the epithelial lining of radicular cysts. Reduced enamel epithelium surrounds the crown of an unerupted tooth. These are ameloblasts that have finished their secretory and their maturing process of the enamel, and they are there in place to protect the enamel before the tooth erupts. If fluid becomes accumulated between the epithelium and the enamel, you then get a cyst forming, and that is the basis of the follicular cyst, that is, dentigerous cysts and eruption cysts. The third source of epithelium is remnants of the dental lamina. Now, these are sometimes referred to as the glands of Ceres. These are most common in the posterior part of the mandible, and they give rise to a number of these cysts and indeed quite a number of odontogenic tumours. Particularly in this context, they give rise to keratocysts and gingival cysts. So here's the tissues that we're talking about. We have in the picture on the left, we've got oral epithelium at the top, and in the dental lamina, that irregular epithelial structure extending into the tissues. And on the right, you'll see it in the context of the developing tooth. There is a primary lamina which comes down, which connects the tooth to the oral epithelium. And then there is the secondary or successional dental lamina, which is going to give rise to the replacement teeth. But once that's all completed, it's not needed and the dental lamina fragments, but you can get little bits of it left behind, mostly in the gingiva. Here's our cell rest of Malassez. That's a remnant of the root sheath of Hartwig in the periodontal ligament. And as I said, that gives rise to the epithelium for a radicular cyst. These will vary in their shape and their size, how big they are, but one thing is true for them all. Under normal circumstances, they're not proliferating, they are quiescent, and so we don't really see cell division or anything like that in them. That is something which needs to be provoked in order to get a cyst lining, which brings us to the second point. What is the stimulus for proliferation? Now, if you remember back to the lecture on periapical granulomas, As the periapical granuloma develops, it is a ball of granulation tissue. Within that, there are lots of inflammatory cells. There are lots of inflammatory mediators and cytokines and growth factors involved in the development of that. And these will all act upon the epithelium if it is present. And they will provoke it to start to grow and to divide. And so that's where you get your starting point of the epithelial lining for a cyst. If it is further up in the periodontal ligament and gingiva, sometimes you can get it similarly for an inflammatory lateral periodontal cyst. And it is true that the inflammation surrounding a partially erupted third molar tooth can be the stimulus for the development of a paradental cyst. What about for the developmental cyst? Well, we really don't know. The dentigerous cysts, there have been very many theories propounded over the years, whether it's the eruptive force and proliferation and these forces starting the accumulation of fluid, and then the hydrostatic pressure brings the osmotic pressure inside. Once you get a little bit of fluid formed, draws more fluid in. The keratocyst, on the other hand, whilst these forces do apply, it also has a greater innate tendency to grow and to divide, to proliferate. And so that may well play a part in the development of these cysts. So we've got our epithelial lining. We've got something to kick it off in terms of it growing and dividing. What happens now? Well, the epithelial will continue to grow and divide. It will form a ball, and eventually the oxygen supply will be exceeded. It will start to break down in the middle, and there will be fluid accumulated with a lot of debris in it, so that content of the initial small cyst will be hypertonic. It will want to pool water into it to try and make it isoosmotic. And then when the water's going in, you increase the hydrostatic pressure, and so it starts to push out the wall. And that whole process continues, and that's how the cysts begin to expand and to develop. And particularly that's the case for radicular and dentigerous cysts. What about proliferation of the lining itself? Well, that is important in some circumstances. As I indicated to you earlier, keratocysts have a greater tendency to grow and to divide themselves anyway, and it may be that there's a particular genetic stimulus underpinning that. And if you were to have a look at proliferation in the lining of a keratocyst, it will be higher than in the other cysts. And then lastly, well, what about getting the whole thing going and creating more space for the cyst to grow and to develop into? Well, again, we're back with our inflammatory mediators, interleukin-1, interleukin-6, prostaglandins, endotoxins, growth factors, and so on. They all act together in controlling various parts of the inflammatory response, but they also stimulate and activate osteoclasts. And this will result in the resorption of bone around the area, and it will allow space for the cyst to continue to grow and to develop. Now in the next section, we're going to have a look at inflammatory cysts of the jaws in a bit more detail.